Good afternoon. We do not have a mic up here, so feel free to get a little cozier if you like. I want to make sure you can hear. Can you hear back there? All right. I guess I am a loudmouth. Well, thank you. We're so grateful for you turning out today to announce this formal clinical affiliation that we've developed between Central Maine Healthcare and Massachusetts General Hospital. As Chuck said, for you that don't know me, my name is Peter Chalk, and I'm the president and CEO of this organization. I'd like to just introduce first Dr. Peter Slavin, who is the president of the Massachusetts General Hospital. He will say a few words after I do. Just in terms of the agenda, I'll make a few remarks. Peter will follow, Dr. Slavin will follow. We'll have a question and answer period. And then our physician panel will then comment on some of the work they've already done with Mass General over the last couple of years and how it's not only benefiting them, but more importantly, how it's benefiting our patients. Let me just introduce some folks in the room. There's a large gang from Mass General, so if they could just sort of wave when I get to your name, wave real high perhaps. Richard Averbuck, Chief Marketing Officer. That's good. See, he's over there. Dr. Amir Fathi, oncologist, MGH, one of the taller ones. Jewel Frechette, Director of Network Development Integration. Downstairs. Downstairs. She what? Downstairs? No, not right here. Okay. Tony James, he's tall, Vice President of Network Development Integration. Kristen Massamine, Director of Network Development Integration, right there. Patty Masson, Regional Director of Network Development Integration, in the back. Dr. Stephanie Moore. Stephanie is a cardiologist, Physician Director of Network Development. You guys have to have some different titles. They all kind of sound the same after a while. Corin Phillips, Network Development Director of the Cancer Center. Dr. Joel Schwartz, Clinical Director, MGH Cancer Center Network. Okay. We have a few board members here from Central Maine. Just acknowledge them. Doug Boyd with the Central Maine Healthcare Board. There's Doug. Bill Chalmers with the Central Maine Healthcare Board and his wife Bev in the back. Okay. Deb Avasi just came in. Deb's the chairman of the Central Maine Healthcare Board. Carlene Tremblay from Senator Collins' office. Thank you, Carlene. Christine Bossi from the Cmmc Board. Thank you, Christine. Ron Pizer, the Cmmc Board. And then Karen Staples from Congressman Poliquin's office. Thank you, Karen. I want to cover, I was telling the group, I'm known to wing it, but I want to cover this right, and I want to put in perspective really what this is all about, because this is very exciting for us at Central Maine Healthcare. And I want to talk about, first I want to talk about Maine. I want to talk about hospitals in Maine, because although we're going to work very closely with Mass General, we want them to understand, and in fact I think many of the physicians that have been up here understand the quality and the scope of practices that we have in this hospital, that we're pretty well advanced. But if you look at the state of Maine, and I'm going to do it from a quality and a patient satisfaction, access, and cost basis. If you look at quality, for the third year in a row, Maine hospitals received the highest Leapfrog patient safety scores in the country. CMMC received Leapfrog A 4 years in a row as the safest hospital in Maine several years ago, similar awards for Bridgeton and Rumford. Patient satisfaction, Maine hospitals tied for first place in Hospital Compare patient satisfaction scores nationwide, and Bridgeton, CMMC, and Rumford all received 4 stars. In terms of access to care, which is critically important all over the country, but particularly in a rural state like Maine, Mainers have local access to care today, largely because 90% of the primary care physicians are employed by either hospitals or community health centers that accept MaineCare, Medicare, all commercial insurance, and provides free care for patients when necessary. Our own Central Maine Medical Group with locations in 21 communities across coastal, central, and western Maine, along with our hospitals, care for a service area of approximately 250,000 people, and we take all patients, again, regardless of their financial status. In terms of cost, we're a relatively cost-effective state as compared to the nation, and we had the pleasure a few months ago, Dr. Atul Gawande was in Maine and gave a major speech up in Augusta. He's a Brigham and Women's surgeon, and he's a healthcare commentator. I've heard Dr. Gawande several times across the country, and he's really become a spokesman for cost and quality. And he said in that conference in Maine that under Medicare, Maine falls in the top quarter of best outcomes and the bottom quarter for Medicare costs. Dr. Gawande's direct quote, "If the rest of the country were like Maine, we'd have tens, probably hundreds of billions of dollars available for everything from infrastructure and education to health." Central Maine Healthcare is committed to controlling healthcare costs, and CMHC hospitals are amongst the lowest cost hospitals in Maine. Internal performance improvement, we use a lot of the lean thinking here, and ACO arrangements that we have has helped us keep our costs down and our quality up. So, giving that little brag, one might say, well, what do we need these guys from Boston for, right? We do. We definitely need these guys from Boston. And for the simple reason, we got to do more. We got to be better. We're not perfect yet, and we still have work to do. We must do more to support our vision of safe, reliable, high-quality care for every patient every day. We want to be assured that wherever you enter the healthcare system, be it in Rumford, Bridgeton, Brunswick, Central Maine Medical Center, or the Massachusetts General Hospital, you get the highest quality of care that is possible. Mass General is renowned as one of the finest hospitals with some of the best doctors in the world. Through this affiliation, we can improve on the care we provide here as a tertiary medical center with 40 medical surgical specialties. In all likelihood, we'll be able to provide more services locally through our relationship with Mass General. However, when this is not feasible and highly specialized care is necessary, we'll be able to seamlessly transfer, as we have now for a couple of years, our patients to our colleagues at MGH. Together, our providers will work to develop the best possible treatment plans for the best possible outcomes with the goal of getting patients home to their families and communities as soon as possible. This is a clinical affiliation agreement. It's not a merger. Central Maine Healthcare and Mass General remain as separate organizations, but the objectives of this clinical affiliation are really to increase the availability and accessibility of comprehensive, high-quality tertiary, quaternary, and other healthcare services in coastal, central, and western Maine, and to improve the continuity, quality, and safety of that care for patients served by Central Maine Healthcare and the Massachusetts General Hospital. We're going to focus on several clinical areas, not all at once, but over the next couple of years, these are some of the areas that we're going to put a lot of work into, seeking ways to improve and broaden the care we provide. The specialty areas that we will initially concentrate on: cancer, cardiovascular, neuroscience, digestive health, and emergency services. We also continue to build on our existing relationship with MGH for our telestroke and neurology services, and we will share best practices in social and behavioral health, and we'll consider cross-training and educational opportunities, population health, management, and research, to name just a few. So I'm very pleased and thrilled that I told the group upstairs I wouldn't say this, but I'm going to say it anyway. We've been working with the Mass General for 4 or 5 years, and I quoted my the individual I worked for years, Bill Young, and he said, situations like this he says, Pete, you have to have a little romance before the marriage. We had a little romance with these guys for about 4 years. Now we want to get a little bit more closer together to see if we can do more things more effectively. So, with those few remarks, I'd like to turn it over to Dr. Slavin for a few remarks.
I guess it's quite obvious that it takes a Peter to run a great healthcare organization here in Maine and in Massachusetts. And it's a great pleasure to be welcomed by this Peter, and also to have had a chance to meet earlier today with some of his leadership team, including Tina Legere, who runs this hospital, Central Maine Medical Center, David Fromm, who runs Bridgeton and Rumford hospitals, as well as Dr. Richard Goldstein, who runs the medical group for Central Maine Healthcare. Peter introduced almost everyone on the team from MGH that drove up here earlier today. I wanted to recognize Kathleen Gallen, who runs our access program for our Heart Center. We are very excited about this, the 5-year gestation that we've had with Maine, Central Maine Healthcare, and now we're looking forward to the birth of this affiliation. This is a very exciting day, not only in the history of Central Maine Healthcare, but a very exciting day in the history of Mass General Hospital as well. As I said to Peter and his colleagues earlier today, we take these affiliations very seriously. We think that we are making a commitment not only to the staff, leadership of this hospital and the physicians, but to the people of this region, and are committed to working together to try to figure out ways to improve care here. And I'm sure in the case of this affiliation, we'll also learn how to improve care in Boston as well. Healthcare is obviously changing dramatically in Maine and Boston and across the country, and the forces that are causing healthcare to change, including a lot of the excitement in medical research and the technology, requires us increasingly to work as teams within hospitals of clinicians in different specialties, teams of doctors, nurses, other professionals working together. But I think we're also learning that it takes teams working across institutions, sometimes 137 miles or more away, to provide the best care possible to our patients and do it as affordably as possible as well. We are committed through this affiliation to trying to do just that, improve care whenever we have that opportunity, and also look for ways to drive down the cost of care so that cost is minimal problem as far as access going into the future. As Peter said, we've been working together for 5 years on such programs as telestroke for patients suffering from strokes and being seen here in the emergency department, trauma, cancer, and heart care. And I think we've learned a lot from those experiences, including the fact that culturally there seems to be a very good fit between the two organizations. Both organizations are first and foremost committed to doing what's best for patients. That's at the heart of the ethos of Mass General, and I think we've seen firsthand that it's really at the heart of this organization as well. So this day marks the birth of this affiliation, and we are not going to just continue to do what we're currently doing. We have ambitious plans for the years ahead. In cancer care, we hope to include the use of telemedicine for consultation and joint continuing medical education opportunities for providers, as well as increasing genetic counseling and case conferences that are already in place. In heart care, we want to work together in areas such as advanced heart failure, transplant, and adult congenital disease. In neurologic care, we have interests in complex neurosurgery, teleneurology, and complex stroke. And in digestive health, we plan to coordinate in activities in adolescents in complex bariatric surgery and other diseases of the digestive tract. And we also hope to find ways to collaborate together in emergency services and, again, improve the quality, safety, and efficiency of our emergency care. We are both organizations are working hard through the Affordable Care Act to be accountable care organizations and do population health, not only for people covered by the Medicare program, but people covered by various commercial insurance plans. And we want to learn from each other about population health management, and again, how we can put in place programs that improve care and drive down its cost as well. So we will be establishing clinical teams of physicians, other providers in these, and I suspect other areas, to try to better identify what the opportunities are and how to realize them in the years to come. And again, this will help ensure that we are working together to improve the health of the populations we both serve. So this is on behalf of all my colleagues from Mass General. Thank you for the pleasure of working with you over the last 5 years during our romance, and now we will look forward to a very long and productive marriage together. Thank you all so much.
Folks, we're going to have some questions and answers now, then we're going to get into our physician panels. Does anyone have a question of the two Peters?
Give me some concrete examples for what this is going to look like for patients.
Well, that's exactly what the panel's going to do, which you can too.
Well, I could say for patients, again, we want to care, we have a commitment to caring for patients as close to home as possible. When they need care at a larger facility, we can transfer them to Mass General. When we've done that before, it's been seamless. The patients have gone there, they talk to the doctors up here. Sometimes that morning, here's what we're going to do at Mass General, and here's how we're going to get you home as fast as possible. Dr. Slavin has told me on repeated occasions, the Mass General Hospital, rather large facility, is frequently full, probably full today. And so he says, we don't want your patients. What we want is the patients that can't be cared for in Maine, and our commitment is to get those patients back as quickly as possible, working with your physicians. So what we're providing is, remember, Maine has a lot of good hospitals. We have 3 tertiary level hospitals: Maine Medical Center, Central Maine, and Eastern Maine. We have no quaternary level hospital. That would be a Mass General, where it has sophisticated research, teaching facilities, and very high-level specialists in all areas. So that's one advantage. But beyond that, I mean, we have a genetic counseling service that's in the state right now. I think that's 1 day a month right now. Nikki will expand that. That's a person coming up from Mass General to provide that service right here in town. There's conferences that are going on between our clinicians already, case conferences to say, what are we looking at? So we can just expand on that. But the real principle is to keep patients home, but when we need a little extra help, we got a big brother that we can rely on and really provide better. But it's all about taking better care of our patients.
And just to give a concrete example of how it's been working up until now, we have a telestroke program where there's actually a video camera in the emergency room here in Lewiston that connects to one of our stroke neurologists at MGH who might be in the hospital or could even be at home. And when a patient with a significant stroke is seen in our emergency department, that telestroke program can be accessed, and that camera can be turned on so that our neurologist can help with physical examination, looking at the imaging, and helping talk with the emergency department and neurology staff here about how best to treat that patient. The vast majority of the time, that treatment occurs here, either with a medicine or with observation or with some intervention, and in the rare instance where that patient needs some procedure that can only be done in a quaternary care facility, that patient would be transported to Boston. But that's an example of how we can use the internet and the expertise of both places to improve the care that's delivered to patients here, deliver the vast majority, as much of it as possible here. And probably before telestroke programs, people with severe strokes would show up at hospitals like this and would be transported to Boston, even though they may not have needed to be. And so we want to try to prevent that and, again, try to optimize the care in the best way possible.
And just with that example, and you know, time is of the essence when you have something blocked within your brain. I was at I can't say where, but I was in a local store just recently, and I asked the woman behind the counter, how's it going? She said, better now. I said, why? What do you mean better now? I said, my husband had a stroke. This is a prior week. Of course, I'm hoping he came here. He did. He had 3 small strokes. We activated that program. Within 42 minutes, he was getting thrombolytics, and he walked out of the hospital the next day, 42 years old. If there was a delay in that treatment, we didn't have access to service, he might not have had quite as good an outcome.
So what is new going forward? I'm hearing lots of expansion, but what's new? What are patients going to see that's new?
We hope to expand telemedicine to other areas where it's relevant. And as I said, I mentioned some of the other clinical areas that we're going to focus on. We're going to need to get our clinicians together in those different areas to figure out specifically what the opportunities are. But we think there are lots of opportunities, and so you'll be hearing more about them shortly. Research,
clinical trials, more expanded clinical trials. Obviously, Mass General has a large research base. The other important thing about this, when we were working with Mass General the last couple of years, it's very fragmented. And now this agreement puts an organizational structure together. We will be meeting once every 6 months between the senior staff at Mass General, the senior staff here. And then there'll be committees in place covering every one of those subspecialties that we mentioned, and they're beginning to get their work. So it'll be those committees that say, what do we want to accomplish next 6 months? What do we want to accomplish the next year? What do we want to accomplish the year after that? So we have a very program structured way of improving patient care across the system, growing and learning with Massachusetts General Hospital. I guarantee you, patients might not see they might not know the difference, but there's a lot going behind the scenes that will make their care a much better experience. Other questions? Wanna,
Yeah. Doug, would you like to talk first? Yeah. I think it'd be appropriate if Dr. Collins from the emergency department, he actually will talk about the telestroke program.
So, I'm the co-director here at the Central Maine Health Emergency Department, both for CMMC, Bridgeton, and Rumford, and Parkview, where we provide their services. Peter has talked some already about our telestroke program. I'll say some more details. It works very quickly that if a patient comes in with stroke-like symptoms, we see that patient brought right back, their CAT scan is done, and at the same time as the patient's rolling in back from the CAT scanner, a neurologist down at Mass General is taking a look at that CT. They're already talking with me, talking with the patient, talking with the nurse, doing a complete thorough neuro exam that would not be possible if you did not have the technology in place of telemedicine, nor if we did not have the partnership with Mass General. So within under sometimes 15 minutes, sometimes 30 minutes, we're able to make a quick decision on whether or not to give a patient a medicine that thrombolytics that has the potential to bring back some of their function, whether it would be some person who cannot talk, cannot move, give them the best chance they can for recovery. So that's something that has worked well. We've also been expanding that into teleneurology, where we have the neurologist on call to talk about other serious cases. Someone may have a seizure who doesn't respond to typical medications, and we're able to get an emergency consult. And that's not something that, especially in the smaller towns of Bridgeton and Rumford, they have access to for someone in person to come and see a patient. And for most hospitals in Maine, they do not have a neurologist who's able to just walk right down to the emergency department and see a patient. And especially in the case of a stroke, these are all time-critical interventions. If the patient needs the medicine, they need it quickly. So this technology that we have already allows us to do that in a very efficient manner, and we look forward to being able to expand that in other neurology cases. Some of the other areas that we're exploring right now to expand our relationship with the Massachusetts General and the emergency departments is more behind the scenes, but what it does for our patients is to ensure that they're continuing to get the best quality of care and also the most efficient care. And the efficiency isn't exciting or glamorous, but it saves dollars, and that in turn means that we can keep this institution open, keep it going, keep the smaller hospitals in the smaller towns in Maine open, and provide services. So that adds benefits down the road.
All right. Do you want to talk next? It's Dr. Dickens. He'll talk about population health.
So I'm Dr. John Dickens. I'm a hospitalist here at Central Maine Medical Center and the medical director for the Accountable Care Organization for Central Maine. The Accountable Care Organization is a collaboration of providers with healthcare institutions like Central Maine Medical Center. It's also a collaboration with nursing homes, sometimes pharmacies, home health agencies, to work together to find ways to improve the quality of care that we provide for our patients, do it at a lower cost, and do it in a way that ultimately we improve the health of all of our patients within the community that we serve. And so talk about healthcare as opposed to the health of our patients. Just take the quality, cost, and health a little separately here. And for a long time, we've always prided ourselves as being an institution and a healthcare system that provides very high quality care. But it's a journey. We're always working to try and provide higher quality care at all times, making our processes as standardized as possible, as safe as possible. And our patients deserve the highest quality care. If it was your family or your loved one, you'd want nothing less. But we also recognize that providing high quality care doesn't mean that you can spend every single dollar that you have. And ultimately, this is the money that comes from the pockets of our friends, our neighbors, and a lot of times our own family members who receive care here at Central Maine Medical Center and Central Maine Healthcare. So we have to have a strong commitment to providing higher value care for our patients. So again, the highest quality care that we can provide, but at the lowest cost. And we talk about population health from the standpoint that we want our patients, we want all of us to live the best quality life that we possibly can and live in the greatest health that we possibly can for as long as we can. And so that is a big distinction from health care, which is the care we provide, to living well and living healthy. So with our collaboration with Mass General, Mass General's been doing population health for a lot longer than we have, and they've had success. And we're just starting along this journey of working to improve the health of our population, of our community. So I see this as an opportunity for us to learn from their successes, to gain the wisdom that they've had, use some of the tools that they've put in place, learn from the failures that they've had. Hopefully they'll share some of those as well. And borrow some of the tools that they've built over the years to provide the higher quality care and to save some money for the patients that we have. Because as Dr. Collins mentioned, we have to do this in a way that is sustainable for our community, sustainable for our healthcare system as well.
Thanks, Joe.
Thanks.
Dr. Fermiento?
Thank you. My name is Carmine Fermiento. I'm the section chief for cardiothoracic surgery, and we've been working with Mass General, our colleagues down at Mass General, for the last 5 years or so, as was said. It really is nice to have an organization such as Mass General to send some patients down to where they're much more complex. These are relatively rare patients, but you will get a patient that has a large thoracic aneurysm that involves both the ascending aorta, the transverse arch, and the descending aorta. These are cases that we might see once every year or two, and if you're only going to be operating on this once every year or two, you probably shouldn't be operating on it. And an organization like Mass General, as a referral center, is going to be seeing that case on a monthly, if not weekly basis, and that patient's going to do much better at an organization like that. And that's one benefit that we get from this relationship and a closer relationship. On the other hand, the real benefit that I'm looking forward to and that we've enjoyed the last several years is in two specific types of patients. The patients in heart surgery that we do here that we think is going to be a relatively routine operation, but lo and behold, at the end of the case, the patient has difficulty coming off bypass. It's a relatively rare event, but from a heart surgeon perspective and from a family member's perspective and from a patient's perspective, that's the worst case scenario. In that situation, you need a system or a mechanism or facilities and technologies to help that patient get through that situation, essentially bridge them till they recover. And there's sort of short-term artificial heart type devices, if I can use that term, to support that patient until their heart gets better. Those devices aren't available here because we're just not large enough an institution to have that device on the shelf. It's very costly. It's very costly to have the personnel. And again, if you're only going to be using that device once or twice a year, it's not financially feasible to try to have a program like that. Mass General now, we're going to have a seamless way of taking that patient from our operating room and getting them down to Mass General to get that device and hopefully get that patient better. There's that benefit. The other benefit is the patient who you can see might be a big problem after bypass surgery. Example, I had a 40-something-year-old gentleman recently who needed bypass surgery, a pretty straightforward operation. The problem was his heart function was severely decreased, which put him at risk of having problems coming off the bypass machine. Now, the technical part of doing that operation was straightforward, and myself and my partner could have easily done that. But then we might have been stuck with a young gentleman on the operating table who we couldn't get off bypass, and we'd be making phone calls. And again, if we had to, that would work. But we could foresee that coming, so we could also make a phone call ahead of time to Mass General and say, hey, what about transferring this patient ahead of time down there and having his primary surgery done down there? Right outside the room, I talked to the device surgeon. They had all the equipment already. If he had a problem coming off bypass, they could have installed the equipment, and the patient could have went from the operating room right to the ICU. Fortunately, the patient did fine, had a straightforward bypass operation, and didn't need the heroic equipment, if you will. But it was immediately available for him, and he did well and ultimately got discharged. So that's where I really see the benefit of this relationship. There's going to be the occasional case that is unusual and really we don't have that much experience with, and if that was my loved one, I'd want it done at an institution that really saw that more often. And then there's the backup aspect of it is if something doesn't go quite right and the patient isn't acting like we want, we have a way to get them out of the operating room and hopefully give them a chance to recover. And then there's a patient, as I mentioned, the third case, where you kind of see that something could go terribly wrong, and we can get that patient down to Mass General and know that they're going to get the best quality care available essentially in the world. So that's where I see our relationship.
Dr. Dr. Jensen, Dr. Erickson, you want to both come up together if you're going to talk about the cancer program?
I'm Dr. Courtney Jensen, radiation oncologist. Radiation oncology is a very technologically driven field. One of the benefits we've gotten already from our affiliation with Massachusetts General Hospital is the ability to transfer patients there that might benefit from some of the technologies they have available there, things like protons, which are available in only a few centers all across the country and nowhere in Maine. They also do intraoperative radiation, which is, again, a very specialized thing that can only be done in a few places in the entire country. They've also helped us pioneer some technology here that's been new for us. One example of that is our stereotactic program, where instead of our typical radiation where we deliver a small dose over many weeks of treatment, stereotactic radiation has the ability to give very few but very high dose radiation treatments. But that involves a lot of specialized techniques to make sure that we don't cause undue side effects and that sort of thing. So when we were starting this program here at our center, several members of our staff took a trip down to Massachusetts General Hospital. We met with their doctors, learned things about how do they select patients for this technique. How do they plan these treatments? What sort of parameters do they look at? How do they care for the patients after the treatment? So that was a very valuable thing for us as we started to pioneer that technology here. Our affiliation with Massachusetts General Hospital has also been important in cancer. There's always new treatments, new things that are being studied on research protocols. So we've often been able to take advantage of those protocols through Massachusetts General Hospital. We've also had many educational programs that Massachusetts General Hospital doctors come to our tumor boards, discuss cases with us, sometimes present research opportunities for those patients. So thus far it's been a very fruitful and productive relationship for us.
I'm Dr. Nicolette Erickson. I'm with the Medical Oncology Department. I don't want to repeat anything that Dr. Jensen said or drag that out, except to just elaborate that we have a great foundation of things we've done in the last few years, and we're really looking forward to expanding that and increasing different kinds of opportunities. And so just as an example of one of the things that I would like to hopefully see us work toward is the concept of a shared visit. So if you think about Skyping with somebody you know, I just think how great it would be if I have a patient that I've shared and collaborated with a physician in Boston, if you could set up your laptop and sit down and have Dr. Fadi and Dr. Rausch and the patient all in the room together, kind of talking and updating. And I just think that would be a wonderful way to be efficient and still tap into the expertise that we might be looking for. And that's just one example. And I think there are probably 10 other things that we could think about, and maybe not all of them will work, but we're going to certainly be imaginative and creative and try to find better ways to bring better care to the people of Central Maine.
Thank you. To wrap up the program, the physician part of the program, we have two patients that want to talk to you also. It's Dr. Jim Riley from our trauma surgery program.
So I guess I'm going last. I'll be brief. I came here from large hospitals in the past, tertiary care centers, and we are a sophisticated level 2 trauma center, and I've only been here 2 years. But in the 2 years I've been here, the relationship with Mass General has been pretty much screaming for infrastructure and some sort of a concrete process to allow us to develop a lot of the ideas that we talk about up to this point, but we haven't really been able to mechanize. So what I see for the relationship is that the people of the community here will see this as a point of entry for some of the more sophisticated care that can be delivered in the country. And with a partner like Mass General, the infusion of academics, resources, the availability to transfer a patient with a very complicated problem just enhances the care that we can give. It also increases our experience with disorders that otherwise might not come here. So 5 years from now, that's what I see here. This is a point of entry where there's not really anything that we couldn't deal with using the partnership and leveraging it for the care in the community here. So two quick examples that I've experienced here. But a couple of weeks ago, we had a guy that showed up with an accidental amputation of his hand in his wood shop. Required reimplantation. That is not done in any center here in the state of Maine. Because of the existing relationship, which is more personal up to this point, that patient was able to be rifled down to Mass General and had it reimplanted, had the hand reimplanted. I just thought that was a phenomenal example of how a true relationship and partnership allows for the care to be facilitated. It wasn't an impersonal transfer. It was actually people who know one another transferring the care. And then another example is about a year ago I was asked to see a gal on the floor here who had multiple liver abscesses. And it was a pretty interesting looking CAT scan with an abscess in every little segment of their liver. Normally I think that patient would probably be transferred to a higher level of care. But the patient was stable, and I would normally just call the transplant guy or gal or have them assess it. We don't have that resource here. So I actually called Mass General's transplant center and within about 15 minutes, one of their surgeons on the phone with me was able to get the films down there, which they were able to read, and get on the phone back with me and say, I don't think you have to send that patient. I think you're right. You can keep that patient right there, and if they get any sicker, then you can send them. And the patient completed their antibiotic course and did well without being moved out of our community, or the displacement of their family, and the need to drive back and forth for 2.5 hours or whatever the scenario might have been. So, it's where are you now, where do you want to be, and how you're going to get there. And I think that this arrangement that's in place right now is the mechanism for us to get where we really wanted to be all along in the last 5 years. And I'm really excited about it, because I think 5 years from now, I will feel exactly like I'm working in a tertiary or quaternary center, because I'll have an army behind me in terms of all the little specialty things that you really need in order to be a fully functioning quaternary hospital, except we'll be using Mass General for those types of resources. And I think the state of Maine benefits from that. So.
Thank you, Jim. If we could have now Bill Chalmers, if you'd come up, Sherry Turcotte. Have two people tell their stories, and you want to go first, Bill? You want to go first, Sherry? Go ahead.
Sure.
Sherry will tell her story about what happened with her at Mass General.
My name is Sherry Turcotte, and I'm both a cancer patient and a cancer nurse. So I think affiliations like this really have the benefit of really putting the patient first. I was diagnosed with breast cancer last August and have been going through treatment since then. And I think the benefit I was able to get specifically through the Mass General affiliation are genetic testing here in my community without driving down to Boston, getting those answers during those critical times when you're trying to make decisions and trying to decide those next steps. It's very time sensitive and it's very emotional during those times. So I think beyond that, it's just having, like was already mentioned, having that army behind you. And I think it's whether you're a high-risk patient or whether you're what would be considered a standard of care patient, is knowing that you have that sort of built-in second opinion, so to speak. It's that combined knowledge and intellect and years of evidence and practice of both the MGH professionals and here at CM that are both involved in your care, and knowing that if anything should change during that they'll be on the phone and they'll be pulling in their colleagues and helping to make those decisions. So I'm fortunate enough to have been able to get all of my care right here in my own community. Since I also work here, it's nice to be able to just run down and get chemo and run back to work and do those sorts of things as well. And it's a benefit that not many people have. So I'm very appreciative.
Bill?
Hello, I'm Bill Chalmers from Bridgeton, Maine. Integrated delivery system as defined by me, community leader and businessman, is a medical term. But I'm a third-generation chairman of the board of the Bridgeton Hospital. We integrated or merged with Central Maine Healthcare Center, and I was very involved in that decision. I was glad that it's been a wonderful decision for the Bridgeton community. It's added tremendous services to my community, and as a result, I'm now serving on the board of Central Maine Healthcare. And so I'm very happy to help on a grander level as well. But more importantly, I would save my life. I was having a little lung breathing issues, was referred from Bridgeton to Lewiston for pulmonology exams, and they determined I needed a lung transplant. So they referred me to Mass General. And so with the great care of Mass General, I had a bilateral lung transplant 18 months ago, and it's truly saved my life. You can see right now, I mean, I'm doing great. They do call me a rock star, so that's appropriate. But, and now they're referring me back here for further treatment at our local community hospital. So I'm a big believer in best advocate of local care, which is critical. But when you need the big guns, you need the big guns. And in my case, that was Mass General for the lung transplant program. So that's my story. But there's one other special person in this room I have to point out, because she authorized my lung transplant. That's Dr. Stephanie Moore from Mass General. So Stephanie, raise your hand. She truly was my lifesaver, because it was close determination as to whether I was a candidate because of my ticker. Could it withstand a big operation like this? And she had to sign on. And after she got through the health issues, she had to look at the character issues. And even regardless of my character, I was granted the opportunity for new lungs, which I'm very appreciative of. So that's my story. It's really interesting to see things from a board level. The fantastic job that this facility does and Bridgeton Hospital does, and I'm very familiar now with Mass General, and I think it's an absolute marriage that's going to make this a long-term, very successful venture. So hip hip hooray, and I'm very excited about this personally. Thank you very much.